Hi, evening friends. I'm Dr. Sushant Soni. I'm from AIIMS Delhi and I'm the pathology faculty with the institute. Now, today let us just have a look at the discussion of November AIIMS 2019 pathology paper. I have around 25 questions of the recall questions which came in November AIIMS. It was with respect to pathology a very predictable paper in the sense that out of these 25, 3 questions were totally new. They were on the new pattern. They would not have been taught to you in any of the classes, not discussed on any app or whatsoever. 3 new topics were incorporated in this paper. The remaining 22 were standard simple questions, out of which close to 18 were pretty straightforward, 4 were application based. We will have a look at that. So starting with the first question that came in the paper, that is match the following. Let me slightly enlarge it. A pretty straightforward question from oncohematology, repeated pretty often, and I guess majority of you would have been right in this. Burkitt's lymphoma is translocation 814. Everybody knows this. Burkitt's is translocation 28, 814, 822. So most common is 814. Follicular lymphoma is translocation 1418. Translocation 1418, that is option 1. Mantle zone lymphoma is translocation 1114. Mantle cell or mantle zone is 1114, whereas the last one, marginal zone, is 1118. So the answer is A. Question number 1, the answer is A. And let us have a look at this again, that is Burkitt's is translocation 814. This is the most common translocation associated with Burkitt's. Mantle cell lymphoma is translocation 1114, whereas follicular lymphoma is translocation 1418. Follicular lymphoma is translocation 1418. Next point. In Burkitt's, chromosome 8 shows the presence of c-MYC. This again is an important point. So let us have a look at MYC also here only. MYC is of 3 types: c-MYC, n-MYC and l-MYC. MYC is of 3 types: c-MYC, n-MYC and l-MYC. c-MYC is a mutation associated with Burkitt's lymphoma. c-MYC mutation associated with Burkitt's. n-MYC is an amplification. n-MYC amplification is associated with neuroblastoma. Please note, c-MYC was a mutation, n-MYC amplification, whereas l-MYC is again a mutation. It is again a mutation associated with small cell carcinoma lung. Next point. So these were the MYCs. Next point. This gets us to the origin of lymphomas. This was last year's November AIIMS question. The origin of lymphomas. I need not even tell you this. The topics which are asked in November AIIMS, a few of those are repeated again in the NEET exam of the same year. So we are having this discussion for the NEET 2020 PG. Next, origin of lymphomas. Firstly, the origin of Burkitt's and follicular lymphoma. Origin of Burkitt's lymphoma and follicular lymphoma. Origin of Burkitt's and follicular lymphoma is from the germinal center. B cells. The origin of Burkitt's and follicular germinal center B cells. Next, the origin of mantle cell lymphoma. Origin of mantle cell lymphoma is from the nave B cells. Versus the origin of CLL, chronic lymphocytic leukemia, is from the post-germinal. is from the post-germinal memory B cells, post-germinal memory B cells, or the naive B cells, or the naive B cells. Better answer is post-germinal memory B cells. That is a better answer. If that is not given in the options, then the next best answer is naive B cells. And lastly, the origin of hairy cell leukemia. Origin of hairy cell leukemia is from memory B cells. Is from the memory B cells. This is origin of lymphomas. Next point, I'm not getting into the markers at this point, CD markers and stuff. We have discussed them enough. Just a quick recap which I'll just speak out. Burkitt's lymphoma is CD34 negative, 19 positive, surface IgM positive. That is Burkitt's. Follicular lymphoma is CD19 positive, CD10 positive, CD5 negative. If you just know that 10 is positive in follicular, you will know everything, because mantle is opposite. Mantle is CD19 positive, 5 negative, 5 positive, 10 negative, versus marginal, which is the poor guy which always passed on margin. So marginal zone is all negative. That is CD5 negative, CD10 negative. These are the markers. We have made the immunophenotypic table numerous times, so I'm not getting into that at this point. Next, this gets us to the next question, that is important interleukin produced by basophils. This was a new topic that was incorporated. Firstly, and is an important point even for NEET PG, because the answer will depend upon language of the question. Have a look. Examiner here asked you interleukin produced by basophils is, and the answer is D, that is interleukin 4. The answer is D, that is interleukin 4. Let us have a look at this. Interleukin 4, it is implicated in, or it is involved in, it plays a role in, it is involved in, or it plays a role in development of allergies. It plays a role in development of allergies and production of IgE antibody. Basophils produce interleukin 4. So it is produced by basophils. Interleukin 4 is produced by basophils. It is produced by basophils and plays a role and plays a response in allergic reactions. Next point, what does it do? It has pro-survival signaling. It has pro-survival signaling in basophils. Delays the apoptosis. It has a pro-survival signaling. Next point, delays apoptosis and increases the effect of interleukin 3. So if the question was asked which interleukin is primarily responsible for maturation of basophils, then the answer would have been interleukin 3. Which interleukin is produced by basophils, then the best answer is interleukin 4. So interleukin 3 and 4 play an important role in maturation and the effect of basophils. Next point, this gets us to the opposite point in this, that is reduced effect. Or increased apoptosis. Reduced effect or increased apoptosis of basophils. Reduced effect or increased apoptosis of basophils, which is by interleukin 18 and interleukin 12. This again is important and can very well be asked. Increased apoptosis of basophils or its anti-effect is by interleukin 18 and interleukin 12. Next, this gets us to our next question, that is question number 3. Question 3. Given as a result of flow cytometry, what is your diagnosis? Now, firstly, throughout the year we have discussed flow cytometry numerous times. I was after your life that it is an important topic. We made the graphs of CD34 side scatter, CD45 side scatter, forward scatter, side scatter repeatedly throughout all the grand tests. We had a look at the principle. Now, what the image came in the paper was CD19. You very well know CD19 is the pan B cell marker. Side scatter depicts granularity. You know this. Now, in the first image, CD19 side scatter is plotted and CD19 positive cells are marked with red color. Examiner also told you that these are the B cells. Everybody knows this, 19 positive are B cells. The second image showed that the normal B cells, the first two set of images were marked as normal. The normal B cells are 19 positive, 40 positive. All of you know how to read a flow cytometry chart. It is like a graph. Both the things are positive, 19 positive, 40 positive. Now, what was asked was the second set of images. The B cells 19 positive are gated, which are 40 negative. 19 positive, 40 negative. That is, it is a mutation in CD40. This is what the flow cytometry tells you. This has been applied as diagnosis, and the answer is B, that is hyper IgM syndrome. This was the second topic that I was after your life, that is diseases associated with adaptive immunity. They were primary and secondary. Secondary main disease was HIV. Primary diseases were divided into B cell defects, T cell defects, combined B and T cell. Hyper IgM syndrome is a B cell defect. Let me write this. Question number 3, the answer is B, that is hyper IgM syndrome. This was an application based question. See, देखो बच्चे, one of the options in that was PNH, paroxysmal nocturnal hemoglobinuria. That is option 3, PNH, will show reduced CD55 and CD59. CD55 and 59 are not given in the flow chart at all, in the flow cytometry plot at all, so that is absolutely out. Chronic granulomatous disease, let me write this one by one. PNH occurs because of reduced CD55 and CD59. I am not getting into more pathogenesis of this, you know that. So 55 and 59 were not plotted, hence this option is absolutely out. The next option was chronic granulomatous disease. Chronic granulomatous disease is defect or deficiency of defect in NADPH oxidase pathway. It is a defect in NADPH oxidase pathway. Again, NADPH oxidase pathway we have seen is tested by, the most common test used is the nitroblue tetrazolium test. So CGD as an answer is out. Next, hyper IgM syndrome. Hyper IgM syndrome is a disease of adaptive immunity, and we can divide the diseases we can divide the diseases of adaptive immunity into two main types, that is the primary diseases and secondary or acquired diseases of adaptive immunity. Main cause of secondary or acquired disease of adaptive immunity is HIV or AIDS, versus the primary diseases, which are again of three types, that is the B cell defects, the T cell defects and combined B and T cell defects. We had, in the previous 3 grand tests in Bhatia's, we have discussed this flow chart repeatedly with all the diseases. B cell defects were, I have a sore throat, B cell defects were Bruton's X-linked A-gamma globulinemia and hyper IgM syndrome. T cell defects was Digeos syndrome. Combined B and T cell defects were SCID. severe combined immunodeficiency, ATM, ataxia telangiectasia, and VASP, Wiskott-Aldrich syndrome. This was the classification. Here I am just stressing upon what was asked in the paper, that is hyper IgM syndrome. Hyper IgM syndrome, this is a B cell defect. This is a B cell defect which has an X-linked recessive inheritance. It is a B cell defect which has an X-linked recessive inheritance and occurs because of mutation in CD40 ligand. Occurs because of a mutation in CD40 ligand. This was what was given in the flow chart, in the flow cytometry plot. 19 positive, 40 negative, hyper IgM syndrome, X-linked recessive. Next, the inheritance of this, it can also be autosomal recessive, but this is less common. Next point, pathogenesis. Pathogenesis. Hyper IgM syndrome. This occurs because of a defect in immunoglobulin class switching. Class switching is not occurring, as a result of which the cells have an inability to produce. IgG. It is hyper IgM, inability to produce IgG, IgA and IgE. Very obvious. IgM has increased. Hyper IgM syndrome. So inability to produce IgG, IgA and IgE. Next point. Clinically, it is associated with recurrent infections. The characteristic one being pneumocystis jirovecii. This is hyper IgM syndrome. Next, this gets us to our next question, that is question number 4. So I'll consider this dot plot flow cytometry as an application based good question, and such questions are the ones which get you a rank. Next, question 4. A pretty straightforward. Which of the following is false regarding acylated phase of CML? Complete response to tyrosine kinase inhibitor. Even if I know anything about CML or not, this looks false, because accelerated phase, CML chronic phase, accelerated phase should not have a complete response. So option 1 is absolutely false. That is the answer. Leukocytosis more than 10 lakh not responding to treatment. This is true. More than 20% basophils in peripheral blood. True. Thrombocytosis not responding to treatment. True. Which is false? 1. So question number 4, the answer is A. Which is false. Complete response to tyrosine kinase inhibitors. A pretty easy, straightforward question. So let us have a look at criteria for CML accelerated phase. Let us have a look at the criteria for CML accelerated phase. First is persistent thrombocytosis. Let me rephrase. Persistent leukocytosis, that is increased WBCs. Persistent leukocytosis. How much? More than 10 into 10 to the power 9 per liter. More than 10 lakh. Persistent leukocytosis, unresponsive to therapy. Next is increasing splenomegaly, increasing or persistent splenomegaly, again not responding to therapy. The next criteria is increased platelet count, that is more than 10 lakh per microliter. We always find it easier to write. Or reduced platelet count, that is less than 1 lakh per microliter. More than 10 lakh or less than 1 lakh, unrelated to therapy. That is in either thrombocytosis or thrombocytopenia, unrelated to therapy. Next is basophils. More than 20% in peripheral blood. Basophils more than 20%. Next is blasts. 10 to 19% in peripheral blood or bone marrow. You know this well. Blasts 10 to 19%. Less than 10% is chronic phase. 10 to 19 accelerated, more than or equal to 20% blastic. So blasts 10 to 19% in peripheral blood or bone marrow. And lastly, any new, last point in this is any new clonal any new clonal chromosomal abnormality developing during therapy. These are the criteria for accelerated phase in CML. Obviously, if it is responding to therapy, then it would not be accelerated phase. I do not want to get into the criteria for CHR, complete hematological remission and stuff. We have already discussed that in our routine classes. This is accelerated phase in CML, a pretty straightforward question. Next, this gets us to a next question, that is question number 5. Question 5. Assertion reason. Assertion is most common finding in lead poisoning is eosinophilia. False. I know it as a fact that it is microcytic hypochromic anemia with presence of basophilic stippling. So eosinophilia false. Reason is lead inhibits ALA dehydratase of heme synthesis. This is true. So the answer is reason is true, that is option. Assertion is false, reason is true. Option number 4. Question number 5. Question 5, the answer is D, that is assertion is false. Assertion is false, reason is true. So let us have a look at this in slight more detail. First point, lead poisoning. Let us first start with assertion. Lead poisoning microscopically causes microcytic hypochromic anemia. It causes MCHC, microcytic hypochromic anemia. Next, it is also associated with basophilic stippling. It is associated with basophilic stippling in RBCs. We have seen this numerous times, the microscopy what it looks like. Next it increases the bone density. Which is detected as increased bone density is detected as lead lines. It is detected as lead lines on the gums. Increased bone density. Clinically, it is associated with colicky abdominal pain. These are the features with lead poisoning. Now, what is happening because of lead? See, ALA formation. ALA stands for aminolevulinic acid. aminolevulinic acid. You know this from biochemistry. Aminolevulinic acid or ALA formation, it occurs which by glycine and succinyl CoA. Glycine and succinyl CoA which condense together. Glycine and succinyl CoA condense together to form aminolevulinic acid. This is occurring in mitochondria by mitochondrial ALA synthase. This occurs because of mitochondrial ALA synthase. Next, it goes to ALA dehydratase and further heme synthesis. Excessive lead stops the action of or inhibits the action of ALA dehydratase. Increasing ALA, lead inhibits ALA dehydratase. It inhibits ALA dehydratase, which was the next step, ALA dehydratase, which in turn goes for heme synthesis. This is the heme synthesis pathway. You know this much better than me from biochemistry. It goes into heme synthesis. Lead inhibits ALA dehydratase. As a result, ALA accumulates. As a result, ALA accumulates in the body and is secreted in urine. This is lead and the role of ALA at dehydratase. So in this question, the assertion that finding is eosinophilia was false, lead inhibits ALA dehydratase and heme synthesis was true. Next, this gets us to the next question, that is question number 6. All are true about CRISPR. CRISPR gene, this is again a question which came last year in November AIIMS also. So we discussed this extensively for the NEET last year paper, that is January NEET 2019. Again a question on CRISPR gene. It is clustered regularly interspace short palindromic repeats, true, used in knockdown technology and forms the basis of genome editing technology. Again B and C. See, even if you knew nothing about this, still B and C are the same statements. If CRISPR is used in knockdown technology, it will form the basis of genome editing. Genome editing is done by knockdown technology. So options B and C were true. And what is CRISPR? It is clustered interspace short palindromic repeats. So all are true except D, that is none of the above. None of the above. All the given statements with respect to CRISPR were true. Next, this gets us to a next question, that is question number 7. Complication of massive blood transfusion, repeatedly discussed. Massive blood transfusion, blood banking is the only chapter in which the previous 4 papers, May AIIMS 2019, November AIIMS 2019, NEET January 2019, previous 3 papers, we had close to 7-8 questions from blood banking. Massive blood transfusion with respect to metabolic complications causes metabolic alkalosis. I am sure all of you knew this. Question 7, the answer is C, that is metabolic alkalosis. Still, let us quickly have a look at complications. Let us have a look at complications of massive blood transfusion. What is massive blood transfusion? It is giving more than 1x in 24 hours or half x in 4 hours. I'll write it on the side. Massive blood transfusion is more than 1x in 24 hours or half x in 4 hours. Where x is amount of blood, where x is amount of blood in body, that is 5.5 liters males, 5 liters females, more than 5 liters or 5.5 liters in 24 hours or half x in 4 hours, that is massive blood transfusion. If you are giving so much blood, obviously it will lead to complications. which are hypothermia, because we could not bring the blood to body temperature, cold blood was transfused, hypothermia. Next, hypocalcemia. In stored blood, calcium is chelated with EDTA, so calcium is less, hypocalcemia. Next, hyperkalemia. Stored blood, because of lysis of RBCs, potassium will come outside the blood, leading to hyperkalemia. Hypoglycemia. That is reduced glucose because RBCs utilize the glucose, as a result hypoglycemia. Next, metabolic alkalosis. This was the question that was asked. Metabolic alkalosis is more common than metabolic acidosis. Both can occur, but metabolic alkalosis is more common. Why? Because citrate is converted to bicarbonate in liver. Sodium citrate is the chelating agent in stored blood. Citrate in the patient's liver is converted to bicarbonate. Bicarbonate is a weak base, leading to metabolic alkalosis. If the patient was in liver failure, it would have led to metabolic acidosis, because sodium citrate is a weak acid. Next, we are transfusing so much blood. Platelets to the नहीं, platelets were not transfused. Hence, it causes dilutional thrombocytopenia. Next, coagulation factors have a half-life. So in stored blood, the coagulation factors reduce. Reduced coagulation factors, which in turn predispose to DIC. These are the complications with massive blood transfusion. Next point, to prevent dilutional thrombocytopenia and DIC, prophylactically, RBCs to FFP, fresh frozen plasma, to platelets has to be given in a ratio of 1:1:1. This again is an important prospective question for your NEET. RBC, FFP, platelet, 1:1:1. Next, this November AIIMS had two questions from blood banking. First question was the one that I showed you. Which of the following is a complication? Metabolic alkalosis. Next, there was an extended matching question on TACO, the answer of which was TACO. TACO. Unfortunately, I do not have the exact extended matching question with me, but TACO stands for transfusion associated circulatory overload. Which is associated with pregnancy, cardiac and renal patients. What happens in these is, if multiple blood transfusions are given, that in turn causes circulatory overload, which clinically is manifested as respiratory distress, and hypertension is common. By hypertension, we differentiate TACO from TRALI. TRALI is transfusion related acute lung injury. You very well know that TRALI is the most common cause of death after blood transfusions, occurs within 1 to 6 hours. Of blood transfusion, and hypertension is rare. This is blood transfusion. Two questions came from this. One was extended matching from this slide, the other one was complication of massive blood transfusion. Next, this gets us to a next question, that is question number 8. Question 8. Which is the best indicator to assess iron deficiency anemia? I need not even discuss this. The answer is B, that is serum ferritin. Best indicator for iron deficiency anemia, the answer is B, that is serum ferritin. Serum ferritin. You very well know iron deficiency anemia has 3 stages. Stages of iron deficiency anemia. So let us make a table with headings as parameter, normal value, normal, stage 1, 2 and 3. Parameter normal, stage 1. Stage 1 is reduced iron stores. Stage 2 is iron deficient erythropoiesis. Stage 2, iron deficient erythropoiesis versus stage 3, which is microcytic hypochromic anemia. MCHC, microcytic hypochromic anemia. Starting with the first parameter, that is bone marrow iron. Bone marrow iron. Stage 1, reduced iron stores. So where is iron stored in the body? Liver and bone marrow. Bone marrow iron reduced. Stage 2 and 3, it is normal. Stage 2 and 3, it is normal. Now every time I have to do iron profile, if I do the bone marrow, patient will run away. It's very painful. So next, which is the most sensitive indicator in peripheral blood? Serum ferritin. Serum ferritin. This is the storage form of iron and is the most sensitive indicator in peripheral blood. Normal serum ferritin is 50 to 200 micrograms per liter. Stage 1, serum ferritin reduced. Stage 2 and 3, serum ferritin is normal. Next is TIBC, total iron binding capacity, TIBC. Normal TIBC is 300 to 360 micrograms per deciliter, normal. Stage 1 TIBC is increased. See, when iron is getting reduced, iron binding capacity increases. Stage 2 and 3, normal. Stage 2 and 3, normal. TIBC. Next is serum iron. Normal serum iron is 50 to 150 micrograms per deciliter. Stage 1 is reduced iron stores. Serum iron is still normal. My mistake. I don't know what I was thinking. See, iron, bone marrow iron, if it is reduced in stage 1, whichever thing is abnormal in stage 1, my mistake, I was distracted, whichever thing is abnormal in stage 1 will also be abnormal in stage 2 and 3. That is obvious. Whatever is normal in stage 1 will also be abnormal in stage 2 and 3. This was my error. Next, serum iron. Stage 1, serum iron is normal. Only the iron stores are reduced, serum iron is normal. It is reduced in stage 2 and 3. Serum iron. Next is percentage transference saturation. See, obvious. Normal serum iron is 50 to 150 micrograms per deciliter. Iron binding capacity is 300 to 350. So transference saturation is about 30 to 50%. Normal is 30 to 50%. Stage 1, the serum iron was normal, so percentage transference saturation normal. It is reduced in stage 2 and 3. And last is peripheral smear. Is normocytic normochromic. in stage 1 and 2. Normally also it is normocytic normochromic. Normocytic normochromic in stage 1 and 2 versus microcytic hypochromic in stage 3. These are the stages with headings as parameter, normal values, stage 1, 2 and 3. Stages of iron deficiency anemia. Next, this gets us to our next question, that is question 9. Question 9. Which causes vasodilation? I need not discuss this. These are the arachidonic acid pathways. Thromboxane, the name tells you, causes thrombus formation. So it causes vasoconstriction and increases platelet aggregation, versus prostaglandin D2 and D2, which cause vasodilation and reduce platelet aggregation. So question 9, the answer is D. The answer is D, that is both A and B, prostaglandin D2 and D2. So this was an easy non-discriminatory question. Next, question number 10. Next, question 10. Von Willebrand factor is formed from endothelial cells. This is something that you know even from physiology. Von Willebrand factor is synthesized from endothelial cells. You also know that factor 8 is factor 8A plus von Willebrand factor. Von Willebrand factor is synthesized by endothelial cells. So I can safely say all coagulation factors are synthesized in liver. I can safely say all coagulation factors are synthesized in liver except factor 8. All are synthesized in liver except factor 8. Because factor 8, von Willebrand factor, is synthesized from endothelial cells. Next, this gets us to question 11. Hepcidin inhibits the function of which of the following? This is a repeat question from last year's NEET PG. It inhibits the action of ferroportin. I guess I need not get into the normal iron metabolism and absorption. We've discussed that. So question 11, hepcidin inhibits the action of ferroportin. It inhibits the action of ferroportin. I am not discussing the repeated questions again because they are easy and non-discriminatory. I want this video to be more high yielding to save your time for NEET PG. Next, question 12. That is, arrange the following in sequential order. Cyclins ABDE. Before I go further, this again has been asked as a straightforward question. This was an application based question. The examiner twisted the language and asked you the sequence. You very well know there are two main cell cycle checkpoints. There are two main ones, that is G1S and G2M. Which is the main cell cycle checkpoint? G1S. The main cell cycle checkpoint, main checkpoint G1S. Next point, how are the checkpoints crossed? Checkpoints are crossed when cyclins bind to cyclin dependent kinases. So let us make the master table of this. G1S, leave one line below this, G2M. We will start making the table from below. Cyclin A and B help in crossing G2M. Cyclin C is not there. Cyclin D and E help in crossing G1S. Cyclins bind to cyclin dependent kinases. So again we make the table from below. CDK21, CDK1, CDK3 is not there, so CDK46, CDK2, CDK46, CDK2. Which is the main cell cycle checkpoint? G1S. Main cyclin for crossing G1S, Cyclin D, which predominantly binds with CDK4, Main cyclin for crossing G2M, cyclin B, B for Bombay, easy to remember, Delhi, Bombay, cyclin B, Bombay, binding to CDK1. Next, this was what was asked. So if I have to make this cyclically or sequentially, first G1S will be crossed, then G2M, DEAB. So the sequence will be DEAB. Hence DEAB. That is option B. D, after that comes E, which is B, DBAC. That is option B. So question number 12, the answer is B. B. Next, if I have to write this as a pie chart, that is G1S, let me make this for you, that is G1S, G2M. If I have, this is the way the cell cycle will continue. Now G1S is crossed by cyclin D, which binds to CDK4/6, Next, after cyclin D comes cyclin E. This is where cyclin E role comes. Cyclin E binding to CDK2. It is the same table which we are making in a flowchart, in a pie chart manner. Next is G2M. First is crossed by cyclin A. The first cyclin that comes is cyclin A binding to CDK1, followed by cyclin B, binding to CDK1. Cyclin A binding to CDK2/1, cyclin B binding to CDK1. So this was the same thing which we had written in the chart, in the table drawn as a pie chart. Next, this gets us to our next question. That is question number 13. Which is not a cause of SCID. SCID is severe combined immunodeficiency. SCID is combined B and T cell defect, which is not a cause. It occurs because of ADA deficiency, adenosine deaminase deficiency, autosomal recessive. Occurs because of interleukin 2R receptor mutations and JAK3, which is not a cause, NADPH oxidase. Now, this was the second question which came from diseases of immune system, that is diseases of the adaptive immune system, that table that we drew, SCID. Next, even if you did not know anything about SCID, you knew from biochemistry that ADA deficiency is a cause of SCID. Okay, you did not know option 2, 3, but you know that NADPH oxidase deficiency causes chronic granulomatous disease. Hence, both ways, I will consider this as a easy and non-discriminatory question. The answer is D, that is deficiency of NADPH oxidase. This causes chronic granulomatous disease. Now, as this has come up twice, so let us just do the test for this also. The most commonly used test for CGD is the NBT, that is nitroblue tetrazolium test. NBT test, nitroblue tetrazolium. Nitroblue tetrazolium in presence of free radicals. Nitroblue tetrazolium in presence of free radicals is converted to formazan. So, if the test is positive, means formazan formation is occurring. If formazan is forming, it means that free radicals are forming. That means NADPH oxidase is acting. If the test is positive, the person is healthy. What are we doing in this test? Looking for the generation of free radicals. So if NADPH oxidase is normal, if it is functioning, it will lead to the formation of free radicals. As a result, nitroblue tetrazolium will be converted to formazan. This is NADPH oxidase deficiency. Next, this gets us to our next question, that is question 14. Intrinsic and extrinsic pathway are related to apoptosis. You very well know apoptosis has two pathways, intrinsic or the mitochondrial pathway, and the next is extrinsic, or Fas ligand pathway. Extrinsic or the Fas ligand pathway. Which is the major pathway of apoptosis? The intrinsic pathway. Intrinsic is the major pathway of apoptosis, associated with leakage of cytochrome C. From the mitochondria. So I can safely say cytoplasmic cytochrome C is responsible for intrinsic pathway versus the extrinsic pathway, which is mediated by CD95. A pretty straightforward question. I am not getting into more details of apoptosis, you know them. It's mediated by CD95. Next, this gets us to the next one, that is question 15. Maltese cross sign. Repeat question from 2018 NEET exam. Maltese cross sign is seen with babesiosis. Question 15. The answer is D, that is babesiosis. Babesiosis is a parasite which leads to Maltese cross sign in RBCs. In peripheral blood. Let us have a look at what it looks like. Maltese cross, it is a cross-shaped sign which was a symbol of honor for Greeks in Malta. That is the Maltese cross sign. Now before we go further, let us have a look at what it looks like microscopically. Starting with the first image, what we see here is the presence of RBCs having both these crossed shaped structures as well as rings. Forget the ring part, have a look at the cross. This is the classical Maltese cross sign associated with babesiosis. Next, having a look at other options, what you see here is the presence of intracellular as well as extracellular small organisms. This is classical Leishmania donovani. That is diagnosis leishmaniasis. This is what LD bodies. All these are Leishmania donovani or LD bodies associated with leishmaniasis. Next, diagnosis. What you see here are small yeast forms. All these are 5 to 10 micrometer yeast forms. They are 5 to 10 micrometer yeast forms with thick gelatinous capsule. Classically seen with Cryptococcus. Classically associated with Cryptococcosis. Just a sec, I was trying to change the color. Classically associated with Cryptococcus. cryptococcosis. These were the other options which came in this question. Next, this gets us to a next question, that is, which condition is shown below. What you see here is a multinodular tumor. Let me slightly enlarge it. It is present on the neck. It has multiple nodules. A multinodular tumor arising in peripheral nerves, and it is looking sausage shape in appearance. This is classical neurofibromatosis, that is plexiform neurofibroma. Question 16. See, have a look at others. Von Hippel-Lindau, this is associated with RCC. VHL gene mutation, chromosome 3. Marfan's, the patient is very tall, double-jointed, dolichocephalic. You know that. This is plexiform neurofibroma. Question 16. Question 16. The answer is A. That is, it is plexiform neurofibroma. Plexiform neurofibroma, which shows the presence of which clinically shows multinodular tumors, arising in peripheral nerves, and causes longitudinal sausage-like enlargement. Of peripheral nerves. Next point, this plexiform neurofibromas, they are associated with neurofibromatosis 1, associated with NF1. Let us have a look at the gene mutations and chromosomes also. Neurofibromatosis 1, the gene mutation is neurofibromin. It is associated with neurofibromin gene mutation present on long arm of chromosome 17q, versus NF2 chromosome 22 gene mutation Merlin. You know that. Inheritance pattern, autosomal dominant. This was neurofibromatosis NF1 plexiform neurofibromas. Next, this gets us to the next question, that is question number 17. Question 17. Now, which is true regarding T cells which express gamma delta type? You very well know T cells have two receptors, alpha beta, gamma delta. Which are more common? Alpha beta. How much? 95% is alpha beta, 5% is gamma delta. Gamma delta T cells, they are present where antigen comes in contact with the body. That is mucosa of oral cavity, GIT and genitourinary tract. Next, so they are present in GIT. They do not require MSC for processing, and they recognize peptide and lipid antigens. They are the first point of contact where antigen comes in contact with the body. So whether you knew whether they need MSC or not, you know that option A and option C are 100% true. Hence the answer is D, all of the above. That is question 17. The answer is D, that is all of the above. All of the above. Next, this gets us to the next one, that is question 18, which is not a small round cell tumor. Retinoblastoma, neuroblastoma, Ewing sarcoma, we have seen their microscopies also. All these are small round cell tumors, which is not hemangioblastoma. So before we go further, let us quickly have a look at small round cell tumors. Again, make a list of small round cell tumors, that is, they show the presence of small round cells microscopically, which are retinoblastoma, neuroblastoma, lymphomas, Wilms tumor. Which component of Wilms tumor is the small round cell? The blastemal component. Wilms tumor, blastemal component of Wilms tumor. Next, rhabdomyosarcoma. Next, rhabdomyosarcoma. Rhabdomyosarcoma. Next, Ewing sarcoma. Ewing sarcoma slash PNET. PNET, that is peripheral neuroectodermal tumors. PNET, peripheral neuroectodermal tumors. All these are the small round cell tumors. Next, this gets us to the next question, that is question number 19. That is question 19. Match the following. First point, BK polyoma virus is associated with decoy cells. Let me first match it and then I'll explain you each of these. Sorry. BK polyoma virus, this was last year's November AIIMS question again. Microscopy was given and you were asked to identify a decoy cell. This time they asked you a written question. So doing repeat MCQs is very important. BK polyoma virus, decoy cells. CMV, cytomegalovirus, has the classical owl-eye appearance. Intracytoplasmic and intranuclear basophilic inclusions, owl-eye appearance. HPV, human papillomavirus, shows the presence of coilocytes, and molluscum contagiosum is associated with Henderson-Patterson bodies. So match, the answer is C, A3B1C4T2. The answer is C. The answer is C. So question 19, the answer is C. Let us have a look at each of these and look at the salient features. Decoy cells. Decoy cells, they are virus infected urothelial cells. They are virus infected urothelial cells which have enlarged nucleus, urothelial cells which microscopically have enlarged nucleus and intranuclear inclusions. Enlarged nucleus and intranuclear inclusions. That is a decoy cell. This can be confused with urothelial cancer, that is urothelial malignancy. This is the significance of decoy cells. We should not confuse them with urothelial cancer. Next, they are used as a prognostic marker. Role. They are a prognostic marker. They are a prognostic marker in polyomavirus BK induced. In polyomavirus BK induced nephropathy. In polyomavirus BK induced nephropathy. This polyomavirus BK induced nephropathy is associated with renal transplant recipients. This is associated with renal transplant recipients. That is a decoy cell. Next point. Before we go further, this is what they look like microscopically. Starting with the first image, it has a large nucleus. The second one, and again, large nucleus, intranuclear inclusions can be confused with malignancy. These are decoy cells, the virus infected cells in urine. Next, diagnosis. Let us first start with high magnification. What this shows is the presence of cells with large intranuclear basophilic inclusions. I hope you are able to make them out. Large intranuclear basophilic inclusions, giving it the classical owl-eye appearance. Large intranuclear basophilic inclusions seen in CMV, cytomegalovirus, giving it the classical owl-eye appearance. Right side was a high power view 40x, left side is the same intranuclear inclusions in low power, that is 10x. The ones I'm marking with the arrow, all this is Aulai appearance associated with CMV, cytomegalovirus. Next, have a look at this. Diagnosis, pap smear. This is a pap smear with squamous cells showing perinuclear clearing around the nucleus. Nucleus is large and black and there is a clear white area around it. Perinuclear clearing. These are the coilocytes. These are the coilocytes associated with HPV infection. Coilocytes associated with HPV. Next, this gets us to our next question, that is question 20. This gets us to our next question, that is question number 20. Question 20. Now match the following: boxcar myocyte array, vacuolations and myocytes and stuff. Now this was the second new question and a new topic which came in the paper. This is a fact. See, we can do two things. Either I can go into extensive details or we can remember this as a fact. These facts, the chances of them getting repeated are low. Boxcar nuclei is associated with hypertension. It is associated with hypertension. Let me write this for you. Boxcar nuclei. Boxcar nuclei. These are rectangular hyperchromatic nuclei. These are rectangular hyperchromatic nuclei. Rectangular hyperchromatic nuclei associated with hypertension. And this is what they look like microscopically. They are the boxcar rectangular hyperchromatic nuclei, hypertension. Next, the next option is myocyte disarray, which is seen in HOCM, hypertrophic cardiomyopathy. Myocyte disarray, myocyte disarray, myocyte disarray, and replacement with myocyte disarray, first point, and replacement with fibrosis, and replacement with fibrosis is a feature of hypertrophic cardiomyopathy, is a feature of HOCM. Next point, the next option is vacuolations in myocytes, subendothelial ischemia. Myocyte vacuolations, which is a feature of subendothelial ischemia, which is a feature of subendothelial ischemia. And lastly, hypertrophy, myocyte hypertrophy, dilated cardiomyopathy. This you already knew. So D1 you already knew. So if you have a look at the options, D1, my hypertrophy is is seen in dilated cardiomyopathy. D1 is only there in two options, that is A and D. Next, A4, boxcar nuclei, hypertension, both were showing A4. B2 or B3, myocyte disarray is in hypertrophic cardiomyopathy. This is the way I would have attempted the question. I know one of these which is only there in two options, so that rules out two and then you go further. So myocyte hypertrophy with enlarged nuclei is seen in dilated cardiomyopathy. This is the way I would have handled the question as a student, even if I knew nothing about it. Chances of marking the right answer increase. Next, this gets us to the next one, that is question 21. Anaphylactoid reaction is immune mediated. False. Anaphylactoid reaction is not immune mediated. Assertion is false. Next, involves direct release of inflammatory mediators without involvement of IgE. True. So question 21, The answer is D, that is assertion is false. Assertion is false, but reason is true. Reason is true. And let us have a look at anaphylactoid reaction. Anaphylactoid reaction, the name tells you it is like anaphylaxis, but it is not. Anaphylactoid reaction, this has the same clinical picture. This has the same clinical picture with anaphylaxis. Anaphylaxis is IgA mediated. This is the same clinical picture with anaphylaxis, but are not IgE mediated. But are not IgE mediated. First point. Next point. They occur through a direct non-immune mediated. They occur through a direct non-immune mediated release of mediators. Non-immune mediated release of mediators from mast cells. So point to be noted here is it is not IgE mediated and it is a non-immune mediated release of mediators from mast cells. This is anaphylactoid reaction. Next, this gets us to a next question, that is question 22. Ewing sarcoma. Now I do not have the exact question with me, but what I have been told is you were asked the translocation associated with Ewing's, and the answer is translocation 1122. Translocation 1122. Ewing sarcoma. On chromosome 22. On chromosome 22 is EWS versus on chromosome 11 we have the presence of FLI1 gene. So Ewing sarcoma is FLI1 EWS fusion transcript. Next, this gets us to question 23. Bone marrow biopsy needle and for procedure, what's not true? Can be done in prono lateral? Agreed. To find out infiltrative granulomatous? Agreed. Breath holding? Not necessary. Agreed. Platelet count less than 40,000 is a contraindication. Nahi bache. Platelet count of less than 40,000 is not a contraindication. On the other hand, if the platelet count is very low, bone marrow aspirate and biopsy are performed to see the causes. So question 23, the answer is D, that is platelet count less than 40,000 per microliter is contraindication for bone marrow biopsy. This is false. It is not a contraindication for bone marrow biopsy. Next, bone marrow aspiration or biopsy. Next, this gets us to our next question. In protein electrophoresis, the band nearest to anode is. This is the last one. Let me show you the image. This is protein electrophoresis and the band nearest to anode was asked. In protein electrophoresis, the migration of proteins is cathode to anode, and the biggest band that is farthest from the point of application is albumin. Easy to remember. Albumin, alpha 1, alpha 2, beta 1, beta 2, gamma globulins. So albumin followed by alpha 1, alpha 2, alpha 1 antitrypsin, alpha 2 macroglobulin, alpha 1, alpha 2, beta 1, beta 2, haptoglobulins, beta lipoproteins, followed by immunoglobulins. Easy to remember. Alpha 1, alpha 2, alpha 1, alpha 2, beta 1, beta 2, immunoglobulins. Done. This takes care of the November AIIMS pathology discussion, And needless to say, bache, it's extremely important for your NEET PG 2021. In case you have any doubts whatsoever, that is NEET PG 2020, and in case you have any doubts whatsoever, you can simply email them to me at sushantssoni@gmail.com. And needless to say, bestest of luck. Do well. Whether you mail the doubts or not, I'm perfectly okay with it, but do tell me the rank that you got in the NEET PG. Take care and good luck.